Hi everyone, good morning. Thank you so much to Flora, Anne-Marie and Chris for inviting us here today. I'm really looking forward to kicking things off. Today's agenda looks great, really interesting, and I'm really excited to hear about the wellbeing realities of living with a brain injury. There are some really exciting speakers coming up, some with a bit more of an interesting background than I have, so hopefully that'll be really exciting to hear from them as well. So just on that note, I'd like to introduce myself, and as Anne-Marie said, I'm here representing the Stroke Association. My role covers public affairs and campaigns for the organisation, but what does that really mean? So really what that means is that I'm the main contact between ourselves as an organisation and the Scottish Parliament and our civil service here in Scotland as well. I don't have any personal lived experience of stroke, so what I'm going to talk about today is really about what I've understood from the many stroke survivors that I have spoken to for this piece of work. As you'll all know, no two strokes are the same, and no two stroke survivors' journeys are the same. A stroke or any other brain injury is a hugely personal event and must be treated as such. In Scotland, there are currently around 128,000 people living with the effects of stroke, and every year around 10,000 people will have a stroke in Scotland. Not only that, but in Scotland we're more at risk of having a stroke, and we're also more likely to have it at a younger age when compared with the other countries in the UK. And at the Stroke Association, we campaign and fund research to improve services, improve outcomes for those people affected by the devastating impact of stroke. So what I'll cover today and what I'm here to talk about really is a report that we published at the end of last year on World Stroke Day, keeping stroke recoveries in mind. The report is centred around the wellbeing realities of life after stroke, and it calls on the government to embed psychological and emotional wellbeing into stroke care in Scotland. I'll share with you the context of why we came to focus and run a campaign exclusively in this area, and I'll also talk about how we approached the piece of work, what insight we gathered, how we gathered it, and the outcomes from that exercise. And then finally, I'll talk about where we are now. So 7 months have passed from the publication of this report and what has developed in that time. As I'm sure you'll be aware, there's been some political changes since then, which has some consequences for our work as well. So firstly, on to the context and the wider kind of reason for this campaign and why we took the decision to focus on this part of the pathway. So it'll be of no surprise to anyone, not least of you guys in the room today, that having a stroke is a traumatic experience for both the person involved and for their families. It's a sudden and abrupt change in function and impacts almost every aspect of their life. Within an instant, someone's life changes forever. And often people associate these changes with the physical effects of the stroke. A lot of people will say that they think of stroke and they think of a one-sided weakness, for example. So there's a real distinct lack of awareness amongst both public and also some healthcare professionals about the psychological needs that can follow a stroke. Now, this is despite, for many years, these needs have been well documented by patients and included in numerous reports, in numerous documents, and even national guidelines over the last 15 years. In 2021, we at the Stroke Association also carried out a piece of work with the James Lind Alliance, and this is a partnership that worked with over 1,400 people affected by stroke and health and care professionals to establish priority areas for research across the stroke care pathway. And they found that psychological and emotional problems are an area that is viewed as a priority for research purposes as well, and that is really fed by and led by people affected by stroke identifying that this is a part of their pathway where they didn't receive the care that they should have. And last year, the Scottish Government also published a progressive stroke pathway document, which is yet another document which lays out the perfect, if you like, pathway for somebody that experiences a stroke. And it covers acute care, so acute in the hospital when you arrive there, ambulance response times, rehabilitation both in hospital and in community settings, and also life after stroke services. And this is quite a momentous document in that it's very well regarded and has many nice recommendations in it, which was endorsed by the National Advisory Committee for Stroke, has support from the stroke community, but there's a real kind of delay, if you like, in this document, which has really great ideas and the reality on the ground. So as I said, despite this recognition, the reality on the ground for patients is really is not great and it's not improving at the pace in which it needs to. Many patients still report, as you'll see in these quotes here, that their psychological needs were not met, were not identified and were not met. And stroke remains to be viewed as a physical condition, and not enough time and energy is given to asking patients about the many psychological impacts that they may be experiencing. So these are just a small insight into what patients tell us, and also what our research and clinical colleagues feel about these challenges. So it's not just that we're hearing these things from patients themselves, but also the clinical colleagues and research colleagues that we work with identify them as well. So it really lays bare the reality of what life after stroke is like. So for all the guidelines that have been developed and the training that's taken place and the changes to service design that have been enacted in some parts of Scotland, there still appears to be a significant gap in how services are assessed and how psychological needs are met, or indeed sometimes not. So not only all of this is going on, but we're also at a unique point in Scottish Government world, if you like, where they were writing their next stroke improvement plan. So the Scottish Government has numerous healthcare plans, I guess, for different conditions, cancer, heart disease, diabetes, and these documents set out priorities and actions to deliver improved prevention, treatment and care for, in this case, all things related to stroke. The last document that they produced is now 10 years old, so as you can imagine, many treatments and practices have advanced significantly since then. So it's now at the point where we're looking to update that document. So they were in the process of writing it and identifying the priorities that they think should be in it. So we had a significant opportunity to influence this plan. And we were steadfast in that the prioritisation of psychological care had to be a pillar throughout it across the whole pathway. So we had then established that this was an area that we were going to focus on and prioritise. So up next, we had to better understand what stroke survivors were experiencing in Scotland specifically, and explore potential solutions to present to the government to address this gap. A lot of the research that I mentioned previously is on a UK-wide basis, and sometimes we can find that there are regional differences. So it was important that we consulted with the stroke community in Scotland to see what they were. Much of this work was done via the cross-party group on stroke, which Anne-Marie mentioned earlier, in the Scottish Parliament. So we were the secretariat to that group, so we are the ones that kind of organise it, and we get to largely decide what the agenda is. So many of the members of this group are from the clinical or research community, so we had a real opportunity to dig into their insights kind of on the ground and learn from them directly about what they thought the challenges were. We held 2 sessions which focused exclusively on the psychological effects of stroke, and heard from clinical psychologists as well as a professor who focuses predominantly on community rehab services, and from Paula, pictured here, who had her stroke in November 2021. Now, as you can imagine, it was Paula's presentation that had the greatest impact. She spoke really movingly about the realities of having a stroke, about how the doctors often failed to ask her how she was doing purely because she looked well. She shared how people would often say, "But you don't look like you've had a stroke." And on the inside, this was really causing Paula significant harm and led to her to really struggle. Her anxiety was completely different to anything that she had experienced before, and that left her feeling quite scared, alone, and sometimes unable to process information or even have a conversation. Now, fortunately for Paula, one of the hospital team, after a wee while, identified Paula's low mood and her anxiety, and they helped her to understand and process what was going on for her. She then learned that despite many doctors only being interested in treating her physical effects of her stroke, the psychological and cognitive effects are also extremely common. And having this explained to her in a way that she understood really helped guide her recovery. And she told us that if people at every level in stroke care understood and were trained to identify these emotional challenges, then everyone would benefit. Following that, we also ran an online survey to understand the distinct lack of prioritisation between psychological care and physical care within stroke rehab. And the results largely confirmed what we had suspected, that almost every stroke survivor experiences some sort of impact on their psychological well-being after having their stroke. But very, very few of them received the amount or indeed any support to help them recover with this part of their journey. We also had the opportunity to hold a number of focus group sessions, which allowed us to gain some more in-depth feedback from our stroke community. And throughout these sessions, we often heard, especially from carers, they often felt at a loss of where to get information. So one person told us that they felt that they were just left to their own devices, they had to find their own information, nobody was forthcoming or helping them with this side of their loved one's journey. Another stroke survivor told us that if they'd been given the information at the start of their journey, it would have helped them a lot to understand. And it was only when they got to the point where they were referred to a psychologist, and that psychologist spoke to them about the stroke as if going through a grief process, that she really began to process everything. So these real-life experiences were invaluable to us as an organisation to shape the campaign and to really give it the real-life kind of impact and reality of what it's like for the stroke community across Scotland. And stroke is a unique condition in that for some people, if they are given the right support and at the right time and enough of it, then they can make a really strong recovery and return to a long, happy and meaningful life. So it's essential that this support is offered at the right time for that individual and it's tailored to that individual's needs. And as Chris said earlier, there's a huge disparity in Scotland around where support is offered, and there's a huge, as you can imagine, issue with regional inequalities and where people can access support. But it shouldn't be that you need to live in the central belt to be able to recover to the best of your ability from a stroke. So after all that insight gathering, we moved on to developing our recommendations that we were going to present to the Scottish Government. And the real kind of backbone to this was a model developed by the Scottish Stroke Psychology Forum, which is on the screen now, but I don't expect you to be able to read that. But this model, it's a four-tiered approach, and it provides a framework which defines appropriate assessment and levels of intervention of psychological need that should be available to those affected by stroke. This model is consistent with what people who have a stroke in England will be entitled to, and it's also consistent with what other long-term health conditions are currently giving in Scotland. So stroke's really the anomaly in that it doesn't have this pathway at the moment embedded in the system, whereas other long-term conditions do. And this model, it recognises the role that all members of a stroke team can play in providing psychological care, and it acknowledges the training and clinical supervision needs of staff to ensure that the psychological care is safe and effective. And this model includes both emotional effects of stroke, such as anxiety, depression, PTSD, but also cognitive effects from a stroke and the relative assessment and interventions that are required. So at level 1, which is the lower tier, is aimed at all health and social care staff, and really it's asking them to be proactive in inquiring about emotional state and having a role in identifying psychological distress. So they can provide compassionate communication, effective information provision, and even just signpost and identify and promote resilient strategies and coping strategies. And a lot of the time when we speak with kind of health and social care staff in this area, a concern that they have is that they don't know where to signpost people to, or they're scared to almost ask someone truly how they're feeling in case they don't have the skills and abilities to help them, when in actual fact, by not asking them, they're doing the patient a disservice. So at level 2, is aimed at more staff with an expertise in stroke, so perhaps people that work in a stroke unit, and they've got an active role in identifying and managing distress and cognitive impairment, and that can include implementation of a psychosocial needs assessment, and with appropriate training and regular consultation with a clinical or neuropsychologist who is embedded within that stroke unit. Staff at this level can then apply psychologically informed practice, which may include things like goal setting, and anxiety management. So it's really essential that there is that clinical or neuropsychologist embedded within that team that other staff members can go to for advice and referrals. The top 2 levels, 3 and 4, are more concerned with intensive psychological support, which is delivered by those clinical neuropsychologists directly. So much of the rationale of this model is that if the bottom 2 tiers of the model are delivered effectively, then many people will not go on to develop the needs that then require such clinical need from those clinical or neuropsychologists. And at the moment, we're not seeing that being delivered, so there's a huge amount of people that are requiring this really quite severe clinical need, and there's just not the staff there to deliver it, unfortunately. So the other recommendations are more concerned with the many conditions that need to be enabled to enact this model to be effective and to be delivered. The model itself it has great support from the stroke community, but it's not just the stroke community that needs to be on board to make it a success. And to really embed this model, there's many other aspects that need to be implemented alongside it. There are a number of barriers that are currently exist, which will have a huge impact on the effectiveness of the model. So firstly is really just the concept of psychological care itself. There's an assumption that someone who has psychological needs may need to see a psychologist, but in actual fact, that's not the case. So while there might be people that do have a range of psychological difficulties, such as depression, anxiety, PTSD, that do require therapeutic interventions from that professional, that isn't always the case. There's a number of other factors that can disrupt a person's mental health, especially in those very fresh stages after they have their stroke, for which a psychologist is just not the answer. So, for example, maybe somebody is in hospital after having a stroke and they would like to FaceTime a relative because that's the person that they normally receive their emotional support from. That is causing them distress and anxiety because they can't speak to that person, but a psychologist is not the person that can solve that. Somebody in IT would actually be better fixed to give that person what it is that they need. So understanding the nature of the distress is really important, and it tells us that there's actually a whole host of people that might be relevant or required to provide the care to address that individual's psychological need. The person who has a stroke will encounter many different medical professions in their healthcare journey, and it's essential that those individuals are empowered with the knowledge and abilities to deliver psychologically informed care. Even in the smallest of actions, as I'm sure many people in the room will know, healthcare staff can contribute to a person's psychological status. Doing simple things like doing what they say they're going to do, coming back when they say they'll come back, and providing the right information in the right way at the right time can all contribute massively. The second barrier concerns workforce, and this isn't an issue that's specific necessarily to stroke. It's a huge issue in the NHS as we at the moment. But when we spoke with the Scottish Stroke Psychology Forum, it was very, very clear that if we genuinely want to address this need of psychological care for stroke services, then there must be a concerted effort to increase the number of those psychologists working with dedicated time to stroke. For many people that suffer a stroke, it's a very unique experience, and they need somebody with expertise in stroke to help them through that journey. It cannot just be a generalist. So it's really vital that this clinical or neuropsychologist is embedded into the service to lead on the implementation of this model. Last year it was reported that there was only 7.6 whole-time equivalent psychologists with dedicated time for stroke to cover the whole of Scotland. And when there's 10,000 people a year having a stroke in Scotland, those numbers just do not make sense. So hence why one of our recommendations is to ensure that the workforce is adequately staffed to be able to deliver this model for Scotland. The final barrier to achieving proper psychological care is around evaluation. So to meaningfully address this issue, we must be able to measure it and to identify where change is needed and to show progress. In many of the acute stages of stroke care, door-to-needle time for certain treatments, so the time to which it takes for somebody to be given the treatment that they need, is measured on an ongoing basis, and it allows services then to focus on the barriers and allows them to improve this time to treatment. But a much broader approach is needed for psychological care and indeed for wider rehabilitation services. And much of this is only known if we actually ask the patients themselves. It's not something that can be measured in such a quantitative way, such as time to treatment, for example. So it's one thing for us to be able to say that a patient received information, but it's only really by asking that patient if we know if it was the right information for them, if it helped them achieve what it wanted them to achieve, and whether it was actually understood by them. So it's therefore really important that the Scottish Stroke Care Audit, who are the current group who audit stroke services in Scotland, do more to engage in meaningful evaluation of patient experiences. And at the moment there's a similar project happening in NHS England whereby they are surveying stroke survivors after they leave hospital to kind of address this issue. So hopefully once that pilot has been evaluated, then it's something that we can look to implement here in Scotland as well. So once we did all that kind of evidence gathering and analysis on the recommendations for the report, we then were able to launch it, which was the fun part of the exercise. So we held a breakfast briefing event here in Edinburgh where we were joined by stroke survivors, one of whom I think was with us today, I don't know if he's in the room yet, Tom, and who had contributed to the report and also spoke at the event very movingly about his the impact on his emotional well-being after his stroke. We also had clinicians who work in stroke care and also politicians who we were hoping would bring this into the Parliament. And following that event, we were lucky to secure a debate in the Parliament on the publication of the report, and the Cabinet Secretary at the time, Hamza Yousaf, responded on behalf of the government, and it was somewhat encouraging, the things that he mentioned in his report. So he acknowledged that stroke as a condition, and indeed this part of the pathway, doesn't really get the kind of the national aiding that it should, and that other conditions with a similar impact do have. And he reiterated that the Scottish Government is committed to ensuring that patients who have suffered a stroke receive the best possible care to live a long, healthy and more independent life. And although he made numerous commitments about mental health and cognitive needs and how that's just as important about physical recovery, we've still got a long bit to go before we see any tangible changes. But it was encouraging to see the now First Minister make those commitments in the Chamber, and something that we can look to bring back up to him in a few months' time. And also one of the more notable kind of policy changes that he mentioned in his speech that day was around 6-month reviews. So at the moment, nobody in Scotland is routinely offered a 6-month review post-stroke. So these reviews provide a real opportunity for people to access support that they may need and be able to enter back into the system in a much more simple way. And this all contributes to improved psychological care for these stroke survivors, because quite often if they leave that acute hospital space or leave their community rehab setting, it can be a real challenge to get back into those services and get the support that they need, and in some cases it's just too much of a thought for people to do, and then they really suffer. And finally, we're also involved in the Scottish Government Stroke Improvement Plan. So I mentioned before that this was a really key influencing opportunity for us as an organisation to shape this plan. And that's so important, because whatever is included in this plan and whatever recommendations are made, that will be what health boards will be told to deliver, and there'll be that kind of national leadership approach to it, where they will hopefully be given adequate resource to deliver it. So if strong recommendations are made around this in this plan, then hopefully it will lead to tangible changes on the ground. So, where are we now? So we're still awaiting publication of that plan. It's due to be published at the end of May, but I wouldn't put too much money on that, knowing Scottish Government timelines, but hopefully it'll be within the next couple of months. We remain Secretariat to the Cross-Party Group on Stroke, which is a really useful tool for us to continue to raise awareness of stroke and focus on certain parts of the pathway which are currently underrepresented. And we also continue to use documents like this, National Clinical Guideline for Stroke, which was published last month, to build more of momentum in this area and to continue to raise the importance that psychological care is for people affected by stroke. So that's really the journey of that campaign. Our helpline here is if anybody needs any support, please do get in touch. We have a campaigns network in Scotland for things like this, where we get our wonderful volunteers and people who are interested to also get in touch with their elected politicians to get stroke on their agenda. And as always, you can always reach out to myself or Jolene, who's with us today, if there's anything else that you'd like to know or are interested in.